Hello and welcome to Strategy Sunday. This is the second More Than a Protest panel discussion brought to you by VIP LA. I am Dr. Jasmine Austin and I'm an assistant professor at Texas State University, and my research focuses on social justice issues pertaining to marginalized populations. Hence my excitement to moderate this panel of amazing participants we have today. So today's panel, we're going to develop a strategy to increase quality healthcare. And this is going to be from the view of the patient and also the healthcare provider. So hopefully we can end here with not only the problems, but also discussing solutions. So when I think about the Black community, I'm not just thinking about in binary terms. I'm thinking about multiple identities that are important to this community. So we're also going to talk about being a Black woman, also being a Black transgender woman, even different abilities and disabilities. So maybe you're physically able differently, or maybe you're mentally able differently. So we're going to try to bring in these identities for a more cohesive conversation. Right. So before I bring in our panelists to give a self-introduction, I do want to take a moment to recognize the lives of two freedom writers and icons and legends. So first we have Representative John Lewis, and we also have Reverend C.T. Vivian. So one of my favorite quotes by John Lewis was, "Never ever be afraid to make some noise and get in good trouble, necessary trouble." So we're going to have our panelists make some good noise today, and we're going to start off with a few introductions. So who would like to get started? Can we have maybe Danielle start us off?
No problem. So hi, everyone. My name is Danielle Johnson. I am a bachelor's prepared nurse. I went to the University of South Carolina in the Beaufort campus. I am currently working at Centero Northern Virginia Medical Center in the DMV area. And then I have also worked at New York University during COVID. And now I'm actually going to be working at Banner Health in Arizona, helping with another COVID unit. So I did ICU trauma at a trauma level 1 hospital, and I'm going to be at another trauma hospital as well this time. I'm also in school ascertaining my nurse practitioner license. I graduated in February, so I'm super excited about that. I have an amazing husband who's in the Marine Corps, and I have 5 beautiful children.
Awesome. Thank you, Danielle. Can we have Dr. Kynard?
Okay, hi, I'm Andrea Kynard, and I'm a physician in general practice in the Los Angeles area. And I have actually was previously a nurse practitioner as well, Danielle. And I currently am contracted with the CDC working in a quarantine station at the Los Angeles airport. But my background is internal medicine, nephrology, which is kidney and renal disease, and in urgent care and emergency rooms. So I'm excited to be here. Thank you.
Thank you, Dr. Kynard. Welcome. And now we have Dr. Tomi.
Yeah. Hi, everyone. My name is Dr. Tomi Obafemi. I am doing my residency at Stanford Hospital in cardiothoracic surgery. I did my undergraduate in Arizona, University of Arizona in Tucson. Did med school in Texas, and now I'm in California doing my specialty training in cardiothoracic surgery. I have some strong opinions about this, especially minority representation in medicine. So I'm excited to be on this panel and talk to you guys.
Awesome. Thank you. We're definitely excited to have you as well. All right, so I'm going to go through our plan for this discussion. So we're going to have 3 different topics, and then we'll open up for questions if we have time. And those questions will come from Facebook. And if those questions are not answered, then we'll post those on our Instagram and Facebook pages. So the first topic we're going to discuss is health disparities and strategies for increasing quality healthcare. And then we'll discuss fostering positive awareness about routine health checks. And finally, mechanisms to educate our community by finding trusted resources. Okay, so I'm going to start with a quote by the Institute of Medicine, and this was in 2005. This quote says, "Some people in the United States were more likely to die from cancer, heart disease, and diabetes simply because of their race or ethnicity, not just because they lack access to healthcare." So I'm going to start with Dr. Kynard, and my question is, do you think this quote is accurate? And if so, how so?
Thank you. I think that definitely people do die because of the color of their skin. And I think that, as I say, some of it has previously been blamed on lack of access to care, but I think that we have tried to bridge the gap for that. But now we're recognizing that there is systemic and even healthcare racism and prejudices that keep people of color, especially from getting all the health care that they need. People, a lot of times, if you know you're always being looked on in a negative way and not respected and not heard, become frustrated, and they tend to not want to go to the healthcare facility and take care of themselves. So I think a lot of times because of that, they don't get the care they need. They don't seek the care that they need, but also when they go there, sometimes they are ignored, not taken seriously, or thought to be troublemakers or asking too many questions, when out of respect, they should be given the time and attention to address all of their needs. So I definitely think it's applicable, and that we definitely have some strategies to work on for alleviating that problem.
Awesome. Thanks, Dr. Kynard. We're definitely going to get into some of those strategies to alleviate the problem. I'm wondering if our other two panel members want to chime in on additional problems that may have stemmed from the quote that I said.
I think a big thing is distrust in the medical system. Going back into some of the history, you have things that happen in Tuskegee with experimentation on Black people when it comes to the healthcare system. I think that some of that stuff is kind of perpetuated throughout time, and even until today. Even with COVID, you see it. There are Black people who are mistrustful of the vaccine. And it's like, oh, don't try it on us first, or you see that quite a lot. And so I think distrust is a big thing. I think socioeconomics plays a big part in it. You see a lot of people who are minority populations who don't have insurance. And so if you don't have insurance, you're not going to be able to see your PCP regularly. And so you see these people who turn up into the emergency department, with things that could have been followed pretty regularly. And all of a sudden you have to get a medicine consult or a surgical consult for someone who hasn't been seen by a doctor for like years. So I think those are two big things. And in addition to what Dr. Kynard said about just being respected, feeling like they're being heard, some people, they go and they're, people look at them like they're a junkie, or maybe like this person just doesn't get it, or they, we tell them the same thing all the time, and they'll never learn, and so they're just written off. So I think those are three big things that people of minority have to overcome to get good healthcare.
So for me, I think the biggest thing would be the lack of culturally competent care and the lack of health literacy. So one of the biggest things when it comes to healthcare policy, we write, and a lot of money is allocated for culturally competent care. So if you look at our Latino brothers and sisters, if they come into the hospital, they have a translator. But if we have an African-American grandmother or grandfather that comes in the hospital and says, well, I didn't have access to get my water pill. Well, if you don't understand what they mean when they say their water pill, then you don't even understand how to even address the issue. So that's a major problem. And if you don't want to learn that healthcare literacy, if nobody's paying for the resources, nobody's paying for the time, nobody's paying for the allocation, and if you don't care, then a lot of times, especially in the hospital, these patients come in as what we call acute exacerbations of their chronic illnesses. So they'll come in DKA, which is diabetic ketoacidosis, because they have diabetes and they were not able to get their medication. They could not afford the $150 that it takes to be able to get insulin on a consistent basis, especially if you're a chronic kidney disease patient. You need it all the time. It's not just because you are having hyperglycemic issues at that time. So if I don't understand, not only that I have to be culturally competent, but you also have to understand the health literacy. And also, if Black people, our pain is looked at as different. So if I go, then there's been multiple research studies about this. So I may go into the hospital, and because I don't show the normal pain symptoms the same way, then I may not get the same level of painkillers, or my pain may not be addressed the same way. So if I feel like that, then why would I go to the hospital? So now I'm looked at as a non-compliant patient. So you have all of these negative stigmas that get placed in this negative language that gets placed on the minority patient. And so if you have those stigmas in your head, can you then actually provide culturally competent care and efficient care and adequate care?
Oh, great. Those are all great points. What I wrote down from what you said was we have issues with respect and bias and trust and insurance, health literacy, and policies, right? I really like your point about, Danielle, about we have translators in the hospital, but we don't also have a lot of help when it comes to biases and how we can mitigate some of that. I also like the idea of biases. So there's the myth of the magical Negro, and then there's the myth of the superwoman. And so I'm wondering, with that, in your work, how have you seen these biases be shown to patients when it comes to healthcare? Have you seen any specific examples? And do you have any strategies to make sure that we don't go back into those situations? Or how can we get out of those situations?
Okay, I definitely, one other point that is that in Los Angeles, California, where I live, for example, there are less hospitals available in the African American Black community as well. And so patients have to, our people have to go further, travel further to seek health care. They don't have the same selection of providers that take their insurance. Yeah, we have the Affordable Care Act now, and that has helped bridge the gap way somewhat, but we need there. So they have Medicaid first, and then if you have more income that qualifies you for Medicaid, then you get Affordable Care Act. And then we still have people, even with that, that still have lack of adequate insurance or no insurance at all. And there are a lot of reasons for that. So I think that we've tried to bridge the gap a little bit, but people still don't have places to go. In a lot of cases, they end up seeking emergency room or urgent care to treat primary care problems, which is not the correct place. But people, instead of the providers being argumentative and upset about that, not enough programs are trying to bridge the gap, and wonder why they're doing that. It may be that they're having to work and they can't take time off of work, and they can't call in sick because they have children or healthcare needs, or they're doing things by themselves. They don't have an adequate support. So we need a system that does, one, to me, is first, hear them, two, give them respect and empathy, and then three, a lot of times it needs to have people who look like them available to take care of them and treat them, so that they can have somebody that has more empathy and understanding of their particular problem and situation. So there are a lot of things that need to be done to address that, as well as more programs that help bridge the gap for the financial or physical needs that they have of getting to the clinics, or maybe the clinics need to be open on weekends and more other hours. There are some community clinics in Los Angeles that do address that. They have Saturday and Sunday hours, they have evening hours, they do callbacks, and they do some other things as well that are wonderful. And they also do a lot of programs in our community clinics that promote sisterhood and brotherhood as well, so that people learn from other people like them, like mentoring and ambassador programs, as well as they have professionals that come in and talk just to them, and that they can ask questions and they get directed, focused attention and answers to their questions. So there are a lot of ways to bridge those gaps.
Okay.
Definitely.
Dr. Kynard brought up a lot of great points. As people in healthcare professions, we do have a platform to speak on. I think generally, there's the AMA, that's like the big organization, but there are people in minority that there are also organizations that we have a collective voice that can make an impact and can lobby in political circles to pass necessary legislations to increase the amount of health facilities in underrepresented areas and provide healthcare to Blacks, Latinos, and other minorities. I think the other thing that we recently just talked about is cultural competency. It's difficult, when you come from a different cultural background, to be able to clearly sometimes communicate your desires or the issues that are ailing you. And so, maybe implementing some cultural competency education within the hospital to help healthcare providers may improve some of that dialogue that takes place. I think a long-term solution that Dr. Kynard also talked about is the representation of minorities in medicine. There's even in my experience, when you have your white coworkers talk to Black or Latino patients, it just doesn't go as smoothly as, if you have another brother talking to a fellow brother, and it just, the understanding is there, of the different issues that they face to overcome outside the hospital, even just to get there. And I think mentoring programs are a huge thing, you know. And so much of the youth feel like this is just not a possibility for them, or they don't know anyone who's in the field, and so they don't really know, if they did desire, how to get to where these people are. So I think mentorship programs are huge to increase the representation, so that we can participate in taking care of our populations.
I think for me, the biggest thing, short term, really looking at how can we create an avenue for those holes that we see. So when I was in South Carolina, I used to volunteer at a migrant camp, and it was a camp essentially for our Argentina migrant farm workers, because that was a huge community. And so a bunch of Latino healthcare administrators got together and they said, hey, our people are coming from Argentina. They're in this area about 6 to 7 months out of the year, and they're having these healthcare disparities. They're living in these areas. What can we do? So they started taking nurses from the community, doctors from the community, and saying, hey, would you volunteer your time to come do blood pressure checks, to come to do OB checks on the women, to look at the babies that were here and say, hey, can you give them immunizations? Can you make sure that they're up to date with their blood pressure checks? What medications can we give them? What resources can we give them to ascertain the medications? And the more I look at it, I always thought that was an amazing idea, but the sad thing was I noticed that in that same area that is 65% African American, those same resources were not there for our community. And so that's short term, one of the biggest things. How can we, and it may mean until we can get our voices heard more, and until we can, as we continue to fight the fight for healthcare administration to see us, we may have to parallel that with a lot of providers and clinicians saying, hey, you know what, I'm going to volunteer my time and go and work in these communities, or create organizations to say, hey, what can we do to create preventative care for our population? Because that's a big problem. Our population is the African American community. We do acute exacerbations for chronic illnesses. So we deal with, oh my God, my sugar is 550. I have to go to the hospital. Versus, you know what, I'm pre-diabetic. What can I do to either because you can go backwards from pre-diabetes, but you can't go backwards from your kidney is functioning at 8%. So what can we do to get to that optimal level of care, where we're at that preventative level of the pyramid versus that tertiary level of I'm now stuck where I'm only able to treat this illness and hopefully maintain it at a level that doesn't progress it. So short term, that's the biggest thing, just trying to create those parallel avenues until we can get the money and the resources. And then long term, I agree with Dr. Andrea and Dr. Tomi, getting providers that look like us and making sure that kids feel like they have the opportunity. I went to a predominantly white school. I had 5 other African-American nurses graduate with me, and like 2 of them are my best friends. Literally, that was the whole program. And so we talked to them about how we felt about that. And so we're going to be doing a panel about that at school. But people like Dr. Tomi and Dr. Andrea, when they go back to their schools in these predominantly white schools like Stanford, and say, hey, you know what, we have a voice. We should be heard. Our patient population needs to see more of us. What do we need to do? How do we get this involved? And also making sure that culturally competent care, like Dr. Tomi said, is a part of the actual didactic. It needs to be a part of the didactic theory. It needs to be a part of what we're seeing in school. It's not just about the A&P and the physiology. You're going to get that part regardless. That culturally competent care, that needs to be forced just as much as acute care 101. It needs to be an issue, because that patient, for the most part, once you already graduated, they don't care what school you went to. You got a degree, they like, treat me. But it matters if they feel like you care and if they feel like they can trust you.
I did want to address, that's what Danielle said is excellent. You did ask for an example. I have seen a lot of times, like when I did a rotation through some OB/GYN, and that there's a lot, 2 to 1 chance of African American babies dying early, from SIDS and other problems, or at childbirth, during when they're born. And part of a lot of the things that they found in the big studies on that is that we don't seek prenatal care early, we seek it late, and a lot of times we're not consistent with it. So that was one of the problems. But the other problem is that a lot of times when a African American woman complains of pain or complications, they are not heard. Sometimes they're not taken serious by the provider, that maybe something is going wrong. There's a complication. I'm not just complaining. I'm not just drug seeking, but I actually have a dilemma here and I'm not feeling well. And that has been shown to be repeated over and over again, that patients aren't taken serious. Their problems aren't explored as well. We know also that African Americans frequently have higher blood pressure at an earlier age of onset than their white counterparts and Hispanic counterparts. And that it is usually harder to treat, more severe and difficult to treat, and that they require sometimes 4 and 5 different medications, and that they need someone who knows how to address that. That is a physician that's culturally aware of those differences and that can do something, knows how to treat that amicably, correctly. So there are things, those are 2 examples that come to my mind that I've seen in the healthcare field and that I've observed directly.
Yeah. Thank you. Those were really great points. What I got from that is a lot of Black patients or patients of color are not being heard. They're not being empathized with. They're not being respected. One solution that we mentioned was cultural competency trainings within and I know we mentioned in hospitals and in healthcare environments, but also needs to start from the beginning at the school level, at the university level. So whenever you start taking these classes, we need to have more classes like these, instead of you being thrown into the situation and then asking, what should I do? And no one has an answer for you, right? So I definitely think cultural competency is one solution for this, but I also want to discuss solutions from a patient standpoint. Okay, so I'm going to give you an example. My dad, he had to have surgery 2 years ago on his gallbladder. And so our family unit was in the room. The doctor came in and was using really big words as if he was in a rush and as if we had no other options, right? And then my brother stopped him in the middle of a sentence and said, "Hi, I'm Dr. Austin." And I immediately saw the shift in conversation and the shift in energy. And the doctor basically went, "Oh, okay, so I can talk to you." And then the conversation changed, the dynamic changed. So not everyone can claim to be a doctor, right, in these conversations. So what recommendations or strategies would you give for patients when they're in the room with a healthcare provider to make sure that they get the best help possible, especially if that provider does not look like them?
I always tell my patients when they're going to a consultation to write down questions that they want to know, write them down, be clear on what information you have, make it concise. Do your research, have your questions. I often give them information and then tell them what questions they need to get clarity on, but to know it ahead of time and be clear on it. The other thing is, if you feel like someone's rushing you off, is that you halt it, and don't do it with anger because it doesn't get you anywhere, but to look at them directly in the eye and say, hello, I need you to just stop and I need this explained in a different way. I'm not following what you're saying and I need to understand this. This is my health and I need you to make this clear. First of all, are you saying this? Reiterate what you think they're saying, get clarity on it, and come back at it until you get it correct. If you're not getting satisfied with that, there are a lot of ways you can go about that. You can say, well, I need to if you don't have time to get another consult, another provider that can talk to you, then you need to say, is there someone else in this office that can help us understand this better? Do you have a nurse or a nurse practitioner here that I can talk to and ask more questions? But you need to let them know that you're not hearing them. And if you still aren't getting what you need to go to your insurance company and complain.
Oh,
and stay good. But my biggest thing is that I think we do have to do a better job sometime in helping our patients be heard in a way that can be accepted and not do it out of anger and frustration. I understand the situation makes them frustrated, but a lot of times when you communicate from that frustrated place, it's just this heightened level of emotions and you don't get your needs met. So I always remind them of the goal intended is to get your questions answered and get what you need out of that encounter. So they have to be clear and precise and concise, and they have to keep their cool and their calm. They have to go go and support themselves. And
yeah.
self-care is a big way of doing that so they can emotionally de-escalate. And we'll talk about self-care, I'm sure, at a later point.
Yeah. Just to kind of piggyback off that, I think that's just huge. I think people are so caught up in everyday life that they put their health very low on their priority list. You know, your health is the most important thing to you. And so if you go into that encounter with that mindset, there's no way you will allow the doctor to leave, or there's no way you leave that situation without trying to get what you came for. And so I think one of the things, if you can, is to educate yourself. You know, there's no better way to go into a conversation with a healthcare provider than to know a little bit about your disease process, because then you can ask some questions. Because a lot of the times we come into the room for whatever reason, whether it be not fully understanding where the patient's coming from, or they're in a rush and they'll say their spiel and then they'll leave, and they'll be like a whirlwind, like you just got hit by a tornado and they're gone before you even had a chance to figure out what you want to ask. But if you have some specific questions about your health and your concerns, and that causes them to pause, to stop, and to begin the interaction. And then, as Dr. Kynard was saying, if you're not getting the answers that you're desiring, even with your specific questions, by respecting your health and prioritizing it, it's your prerogative to speak up respectively, but to demand those answers, because it is your health, and it should be the number one thing for you.
So I think that question is kind of twofold a little bit. So if you're looking at the outpatient perspective, I think the biggest thing that we can do is, like Dr. Kynard suggested, is just making sure that you understand, because of the situation with how many patients a lot of, especially outpatient providers, see, especially unfortunately in minority communities. Normally you'll have about 30, sometimes more patients a day. So you may not get as much education as you would like. So if you can concise that, if you can write your questions down prior to, that's a big thing. Also, I know for me, like my grandmother, my family calls me anytime, even both of my grandmothers, to be honest, anytime something's going on, if you have somebody that halfway speaks the lingo, especially for a geriatric patient, because a lot of times they go to the hospital, like, I have no, they go to the doctor, like, I have no clue what they're saying. I don't know what A, B, and C meant. I think they said this and it could have been something completely different. So it can be very scary if they go alone. My grandmother went to the hospital alone, for example, to the doctor alone. She was bleeding. She's 88. And she's, she comes back and she's like, the doctor told me I have cancer. And I'm like, wait, whoa. So the whole family is up in an uproar. And I'm like, we need to have another conversation, even if it means getting another doctor. So I think number one is just, if you have somebody that can advocate for you in the family, especially for our geriatric population, then take that person with you if they're willing to go. If you don't have anybody that can advocate for you, to the best of your ability, make sure that you can concise everything down, write your questions down beforehand, research as much as you possibly can. And then when you're looking at the acute care setting, it's a little bit different. Because the doctors come in, and I see it all the time. It's so sad because they wait all day. They're like, I don't know what's going on. I don't know what's going on. And the doctor comes in for like 5 minutes at 9 a.m. and they're like, I was up all night. I don't know what they said. And so a lot of times the nurses, if you build a rapport with your nurse, if you can, nurses can be they are not the doctor. So we do, as a nurse, we do not diagnose you. And a lot of times we'll tell you, they'll be like, well, did my scan come back? And we can say, okay, it came back. I'm not a doctor, so this is not my diagnosis, but I can interpret this for you. So as a nurse, I can interpret different diagnostics. Now, as a nurse practitioner, it's different because they're a provider level. But as a nurse, I can interpret readings for you. I can maybe explain something a little bit better to you. So if you can build a rapport with your nurse, that is a really good way to get a different version of what the doctor's saying. And because you're going to have 12 hours with that nurse, where you may only have 20 minutes to an hour, depending on what's going on with that doctor. So that's one good strategy, is building a rapport with your nurse, making sure that when your doctor comes in, if you, if it's a geriatric patient, I tell my patients all the time, hey, do you have a daughter? Do you have a son? I'll write a note in their chart and say, call, I don't care if you told the patient, because it is the responsibility to tell the patient, but call their secondary person and make sure that they understand what's going on as well. I'll put their number on the board. I'll also write a secondary note, because documentation is really big. So I tell my patients, hey, make sure that whoever you have, that they write, whoever admits you or whoever your nurse is, make sure that they write an additional source for you. Make sure they write that information down, so that that doctor has multiple people to talk to, so that that information is funneled to you by people that you care about. So that kind of adds in that trust level that we've been talking about, right? And then another thing with the acute care setting, if you feel like you're not getting what you want, like Dr. Kynard said, on the outpatient side, go to your insurance company, complain. You have power. A lot of times, especially with the geriatric patient, they don't want to talk to a doctor. They're scared. They don't, oh, I only have Medicaid. Maybe that's why I'm being treated this way. No, we get 100% payout from Medicaid just for you laying in that bed. So you have a voice, use it, use your power. On the outpatient side, and also on the inpatient side, we have nurse case managers. I'm a charge nurse at my hospital. You can always escalate to the charge nurse. You can always ask for a nursing administrator. You have power. And for us, like Dr. Kynard said, we don't have to get angry. I don't have to get angry, because I can go above you to make sure that I get what I need. So if you walk into it like, this is my care, and like we will walk into any other part of our lives that we care about, we have to start advocating for our health, so that us as a community, we can thrive. Optimal health and adequate health and efficient health, all of that has to come from you saying, you know what, I'm going to take this and I'm going to make sure that people hear me and people see me. So you have a voice, you have powers. I think if you look at all those strategies that we talked about, those are some ways to kind of get a good step on that.
Awesome. Thank you. I want to stop just for a brief second just to thank the panelists. Y'all are all staying on task. Y'all are giving us specific strategies. This is making my job very easy. Okay, so based on this last question and these answers, I wrote down 6 strategies. All right, these are 6 strategies to help better our experience with healthcare. All right, so we discussed writing down questions beforehand, slow them down if you feel like they're going way too fast, and get clarity. And you can ask them to explain things in a different way. Another option is educating yourself beforehand. And what I'd like to add to that is educate yourself during, because you can do a quick Google if you want to while they're right in the front of you, and that's completely fine. Another suggestion was having a representative or an advocate. If they're not there physically, you can still call them if you need to. Building rapport with your nurses and additional healthcare providers. And then the last, and my favorite, which is some information that I didn't know, is that you can complain to your insurance provider. So I'm going to put that one in my back pocket. All right. So we discussed a few of these strategies, and I feel like we're moving towards the second topic of fostering positive awareness. So I want to ask an extremely basic question. All right. So getting back to the basics, we talked a lot about preventative healthcare, preventative care. If you can think of a few illnesses or diseases or just health concerns, what would you say should be on the list of preventative care that we should focus on?
Definitely for preventive care, diabetes mellitus, big time. Hypertension is a little more difficult because a lot of times there is a genetic predisposition for it, but things can be done to prevent it and make it more manageable. So I would say coronary artery disease, and within that is hypertension, definitely. And obesity would be my third third one. And then lastly, cancer, if know it or not, is in some realms preventable because of lifestyle habits and other things that can lead to it, as such as obesity, not getting your screenings early, not taking care of precursors for cancer. So those four are in top priority, and those happen to also be in the top realm of the top medical diseases that people die from, and people of color die more often and more and younger than our counterparts. So definitely, again, coronary artery disease, diabetes, hypertension, obesity, and cancer are all five of those, but those are the ones I suggest.
From a surgical standpoint, I think the number one cause of death for people worldwide is heart disease. And just like Dr. Kynard was mentioning, some diseases that fall under that umbrella that contribute to that are diabetes, hypertension, elevated cholesterol, and obesity. Now, I'll tell you, if you have diabetes, it affects you in so many ways. People just don't realize. I think, people think it's such a benign disease, but you could lose your kidneys, you could lose your eyesight, you could have wounds that get out of control, that then you have to come see a surgeon. All of a sudden you're losing limbs. Hypertension, that can mess up the arteries in your body, that can mess up your heart, that can mess up your kidneys. Cholesterol, that can mess up your heart. Obesity, if you ever have surgery and you're overweight, the complications are way higher from wound infections. It makes the operation more difficult. So these are all things that are, if you have a regular primary care provider, that can be managed and prevented from becoming problems that kind of lead to other bigger problems.
So for me, I definitely piggyback off what Dr. Tomi and Dr. Kynard said. With chronic kidney disease, we see that so much, especially in the acute care setting, especially in the African American population. According to the CDC in 2019, there was about chronic kidney disease was about 38% more prevalent in patients 65 and older, and it was 16% more prevalent in African Americans. So, it was like chronic kidney disease is like a double whammy, but that chronic kidney disease a lot of times is precipitated by diabetes mellitus. So again, diabetes is a big one. Heart failure, especially in African American women, ages about 55 and up, Black women are dying at rapid rates from heart failure right now. And that's a big thing that, we're trying to address in the medical community, but it's kind of new statistics on that. But it actually has been a big push, especially with the American Heart Association. Also, prostate cancer, and specifically when it comes to prostate cancer in Black men as well, is a big thing a lot of times because we check late, or we feel like, checking that area. But Black men are actually, prostate cancer in Black men is the highest cancer that they're actually dying from, that we're seeing death from right now. And then the other thing for me, especially because I'm from Atlanta, Georgia, but one of the bigger things that we see, especially in the southern states like Florida, South Carolina, Mississippi, Alabama, Louisiana, that area, that cluster right there, is usually chronic kidney disease, diabetes mellitus, hypertension, and STIs. And that's also, earlier you talked about our LGBTQA community. That is a big issue right now. So STIs are actually very, very rampant in our community right now. And the biggest ones that we're seeing right now are, in the hospital, a lot of times we're seeing exacerbations of chlamydia, gonorrhea, and then syphilis in the maternal patients. So that's something that they're not checking. B, the check-in pretty much is down 32%. And then the medication regimen, they're getting the medication regimens too late. So essentially what's happening is that either they're getting multiple STIs back to back, or they're at a place where the STI has gotten so bad that now they need to be admitted to the hospital. And a lot of these STIs have major health factors. With syphilis, if your baby comes through the birth canal with syphilis, that baby can be blind. With gonorrhea and chlamydia, it's the same thing. In women, if gonorrhea or chlamydia gets too bad, it can turn into pelvic inflammatory disease, which can also affect your ability to have a baby. It can affect your fallopian tubes. Your fertility rate can drop if it goes too far. You could put yourself at risk for a hysterectomy. So there's a lot of things. So STIs is a big one, especially like I said, in that southern states area where a good majority of the African American population live.
Awesome. It seems like we can all agree on a few different items that were mentioned. So we can all agree on obesity and hypertension and cancer, especially prostate cancer, coronary illnesses, kidney disease, heart failure, right? I know we did not mention nutrition as much because that's definitely a preventative measure, but I'd like to hear one, maybe how nutrition can help with these preventative measures, but also how have you noticed in your practices these preventative care measures could have helped or can help when it comes to COVID-19? So what are some ideas when it comes to nutrition, and how are these preventative measures and what we just mentioned, how can that affect COVID-19?
Okay. I definitely think that nutrition is key to all of the diseases. So there is a lot of what they call physiological nutrition, but where you can use nutrition to heal yourself. So one, nutrition can do to lose weight and direct and prevent obesity, along with exercise and healthier eating choices. But there are also some nutritional things that you can do, certain foods that help you eat better, to help you, have antioxidant properties and help you to build up your immune system. And specifically for COVID-19, there are a lot of nutritional and supportive therapies that you can do to help improve your immune system. Elderberry, using elderberry tablets and things, plants. Also using zinc oxide to help build your immune system and help as I said, antiviral, as well as eating well so that you are in your best health state, so that you don't fall and succumb to diseases as easily. Is another way of getting proper rest, not drinking too much alcohol and not smoking. All of those things can help protect your system so that it can fight off and fend off infections and diseases more, especially COVID-19. Just being in your best health state is part of that. And at some point, I don't know if we'll have enough time to go into this later, but I think a big thread in all of this is self-love. So as African Americans, I think a lot of things stem, as Danielle said, that we have a lot more STDs. And I see a big thread when I worked at a community clinic, that sometimes women find themselves in some situations where they think that's what they need to do to get through. So they may have more partners, may put up with something that they may not need to be putting up with. Not that I'm judging them, but I see that a lot of times I just have the empathy of wondering why would they continue to put themselves in a situation where they're being exposed to some of these diseases. And a lot of it falls back to that lack of self-love, that lack of letting other people define you and who you are, and seeing yourself through someone else's lens as being this unhealthy person that's not capable or not worthy of being loved and self-caring and getting the care that you need and being at your best game. And part of disease prevention is a healthy state of mind, a healthy body, being holistically well. And so nutrition plays a big part, as well as I eat the right foods, I have access to the right foods, I seek the right foods, I'm knowledgeable about. Who were the first witch doctors? Who were the first herbalists? We were. And we don't go back to our history enough in time to rely on that and be knowledgeable about that and not fall prey to what's put into our communities to feed us, the fast food, the non-nutritional food that's out there, and a lot of things. So it's all a big web, and I could go on and on, but I'll stop so everybody else can talk.
I think, as Dr. Kynard was saying, prioritization of your health, I think, is what it comes down to for me. People, I know life gets really busy, but people, if we prioritize our health, then we're able to take the necessary steps to maintain good health. There's something called the DASH diet that's used particularly for hypertension, but it involves foods like fruits, vegetables, lean meats, grains, fish, poultry. These are foods that are tried first before people are started on medication for hypertension. So by eating properly, by giving your body the correct fuel, you can actually maintain a good blood pressure or keep your blood pressure within decent limits without having to resort to medication. I guess also those same foods can lead to better control over your sugars. Those same foods can lead to better control over your weight. And I think nutrition is not only limited to the food. It includes smoking. I can't tell you how bad smoking is. It affects so many organ systems. From general primary care sense, and in surgery, goodness, smokers, their risks are just through the roof. I mean, and then alcohol, too much alcohol disease. I can't tell. I wish I could show you pictures of alcoholic liver. And alcoholic liver looks horrible. Like if people really saw the picture of a liver that's been ravaged by alcohol, I think a lot of people would stop. Even the heart doesn't do well with that much alcohol. It causes all sorts of different disease processes. And so I think, education of these things is huge, but also just prioritizing your health. Because if you prioritize your health, then you look into these things and then you can take ownership of it as well.
Awesome. And before we move on to Danielle, I have a follow-up question for Dr. Tomi. You mentioned a diet. What was the name of that diet?
Diet.
I'm sorry, one more time?
DASH, DASH.
Oh, awesome. Okay.
Yeah.
I feel like someone tuning in is about to Google that real quick.
It actually stands for Dietary Approach to Stop Hypertension.
Okay, dietary approach to stop hypertension. Awesome. All right, I'm so sorry, Danielle.
No problem. That's it's a big one. So I'm glad we clarified that. As far as COVID-19, one of the things that I've been seeing is like Dr. Kynard said was zinc oxide was a big one. Also, things that you can do as far as vitamin C is a big one. One of the things that a lot of people don't realize is that when you get COVID-19, we do not have a treatment for that. Unfortunately, we are trying a bunch of different things, but we don't have a treatment for that. So one of the things that we were seeing is that we were giving people's D-dimer, which is a lab value that we test to see if somebody has a clot. So if you have a stroke, if you have a DVT, which is like a clot in your lower extremities, that number was extremely elevated. So when COVID-19 first started, one of the things that we were doing, we were putting everybody on an anticoagulation medication called heparin. So that basically we were trying to stop people from clotting. But what was happening is mainly to a lot of Black people, which is why Black people are dying at a higher rate, was that it was causing them to internally bleed because they already had the pre-existing issues of heart failure and coronary artery disease. So we were stopping them from clotting, but then we were causing them to bleed too much. Also, when they were having the heart failure, another subsidiary medication that we were giving them was causing a part of their heart segment to be too long. So that essentially was causing their heart to beat erratically. So we couldn't wean them off of the oxygen precautions. Their heart was now beating erratically. So we were having to put them on other medications to control the heart. And we were also having them on medications not to clot, but then they were bleeding internally. So you can see how not having that optimal health, when you have something that affects your system, it puts you at that much higher rate. So I tell people all the time when they go out now, washing your hands is like the biggest thing you can do. Another thing is like nasal lavages, just kind of when you're out, washing your nose out, washing your mucous membranes out, Visine drops, washing your eyes out, because you know we wear the mask, but another mucous membrane is your eyes. So washing your eyes out is a big thing. So those are kind of just some of the precautionary things as far as COVID-19 goes. Now, as far as the nutritional factor goes, that's kind of a double-edged sword, because our community, number one, because of some of the other issues that we have as far as resources, as far as access. So I know when, the things that I feed my kids, unfortunately, when I was growing up, that wasn't necessarily an option at that time. So I may go to Trader Joe's now and spend $3 on a small carton of almond milk, right? Because I don't want to give my kids vitamin, the whole milk, right? But I have 5 kids, and a small carton of almond milk is like $3 per. So I'm going through, maybe 6, 7, 8 bottles. But when I first started school, and me and my husband were first starting out, and he was like a E4, and I was in school working at a gas station, I could not afford to give them. So part of it is educating yourself and doing better. But part of it too is trying to figure out, okay, how can I make these small changes to my diet to help and also accommodate your finances and accommodate what stores are in your area? Because we all know that a lot of times, especially that we saw very much with COVID, there's a lot of food scarcity that our community deals with as well. So a lot of times what I tell people, especially my patients that have heart failure or diabetes, I tell them make small changes. So I tell them everything in moderation, because people think, oh my God, I got to change my whole diet. I grew up on this food. It didn't kill my grandmama. It ain't going to kill me. If you tell people everything in moderation, if you tell them, hey, you know what, how about you switch out, the bacon for turkey bacon? Not only is it cheaper, but it'll keep you down on the fat and the saturation. How about you switch out, if you don't want to go drastic as almond milk, how about you switch out the whole milk for 2% milk? Same amount, same money, right? So you're in that same range. But you're making a better health choice for yourself. When it comes to the fast food, a lot of people in our community work 2 and 3 jobs. I work 12-hour days. My husband works 12-hour days, and we have 5 kids to feed. So if you can meal prep. So what I do is normally me and my husband will take one day and we'll crock pot, so I can, if I have a night shift, I'll sleep while the food is cooking. Or we'll meal prep for the week if you can do that. Chicken, if you can get the lean chicken, even if you can't afford the lean chicken, if you can swap out chicken for red meat even 3 times a week, that's helping with heart disease, because one of the biggest contributors of heart disease is red meat. So if you can swap more chicken, you can say, okay, we're having tacos tonight, but I'm getting chicken. Even if you don't get the lean chicken, you can get that pack of chicken for $3-4, which is pretty much comparable to what you would get that beef for. So just small changes that you can make in moderation that keep your budget where it is, and where you're not making drastic changes, so that you can slowly make those changes until you're like, oh, okay, I'm not, that's not so bad. But those small changes lead to that optimal health that Dr. Kynard and Dr. Tomi are talking about.
Awesome. Thank you, Danielle. We can definitely see that Danielle is definitely a nutritionist specialist, which she discussed before the panel started. So I'm glad she had the floor to be able to give us those suggestions. What I do want to do before we move on to the next section, which is mechanisms to educate, I want to open the floor one more time, because I saw our panelists had a lot of head nods and agreement, and I'm wondering if you had any other additional suggestions. So what we've talked about so far with this idea of nutrition and preventative health is prioritizing our health. We talked about the DASH diet, elderberry, zinc oxide, talked about washing hands, Visine drops, nasal cleansers. We talked about changing our little changes in our diet that can help out. Do you have any other suggestions across the panel of what we can do that's something that's like a hard plan of strategies that we can do?
I think self-care is another one that people need to find ways to de-stress. And with that, eating right also plays into that. When you eat a heavy, greasy diet, you're more stressed out, believe it or not, if you're drinking a heavy amount of alcohol, because we have some of the higher rates of liver disease and alcoholism. Of course, if we could go on about all the worst comorbidities that we have, I think we are becoming more educated and knowing what we should and shouldn't do, but not smoking, reducing your alcoholism, as Danielle said, reduction and making small changes is probably a good thing. And I love what you said about maybe I would think, yeah, I may would want to tell somebody, recommend that they go do almond milk or something like that, but maybe they can't afford that. So, and I can't believe, I don't know where you live, Danielle, that almond milk is $3. It's $1.50 here, but okay.
Oh, it's like so expensive. Even when we were living in California, it was, I was like,
I'm in California, at
yeah,
Trader Joe's, it's $1.83.
No,
It's like $3.
yeah, San Diego is pretty expensive.
Oh yeah,
It's
San
like,
Diego is
it's
expensive.
like, yeah, it was like $2.96 per. Like,
oh, well, one thing about that, I don't know if you guys have those, what is that grocery store? There are a lot of African American minority chain stores here. I'm thinking, oh, Grocery Outlet. Grocery Outlet frequently has wonderful products, brand name food for less. I don't know if they have those in your communities, but Grocery Outlet is a great resource. Um, as well as ordering some of those things online. Sometimes you can get bulk for a cheaper price as well. And then the other thing is turkey is a wonderful food to eat. Turkey hasn't been associated with, it's high, low in fat, low, you do have to add more seasoning to it, but doesn't need to be salt necessarily. You just have to learn how to cook it. And I love what Danielle said about the crock potting or the pressure cooking, cooking overnight, doing, you know, two things at once while you're doing that. But I do see a lot more whole food uh, markets or outdoor markets, not as much during COVID-19. These haven't opened back up, but farmers markets, that's the word I'm looking for. But farmers markets are a wonderful place to get fresh fruit and vegetables, but growing your own market, your own garden, which is cheap to do, and you can do it in a big pot and you don't have to buy an expensive one. There are really good ways to make your own. My son has just taught me how to do that, where I have a big pot and I'm growing actually garlic, zucchini, carrots, and kale, and all in this one big pot that I'm, a big planter rather. And it wasn't a very expensive endeavor to do, but doing all of those things. But self-care comes by starting to be aware and knowing what you need to put into your body, getting the rest you need, getting the proper exercise, talking to people who need to give you good advice, and being spiritually balanced. You know, for me, it's religion, and I believe in God, and I know that God perfects all of my ways and guides my steps. But being spiritually grounded as well is a big way of dealing with all of this.
And then for me, I think one small thing I think I could add is as much as possible. I know sometimes many people work multiple jobs and it's hard to be at home and cook, but home meals are not only have less processing than fast foods, they tend to be healthier. You then tend to spend more time as a family unit together if you do home meals. I think there are many different websites that have ideas for cheap, quick things that you can make that could feed a family. And I just think that being able to cook at home is not only healthy, but also supports the family unit as well. I think there's many benefits to that.
I think my last one is mental health. So, you know, that doesn't really get talked about in our community as much, but it's a huge factor in our community, even though it doesn't get addressed. So mental health is the biggest thing that you can do for yourself and for your family. So whatever that looks like for you, just making sure that you have that optimal mental health. People think, oh, you know, I need to go talk to somebody because something's wrong. But a lot of times just having anybody to talk to hear you, to bounce ideas off of, to strategize, to I use, for my kids, I use my mom, I use my grandmother, I use my husband, I use, it's a community. So if we treat our mental health like a community as well, then, hey, my sister, this is what I have going on. What do you have going on? How can we support one another? So really, I think mental health is one of those things that if we're going to talk about health, and that, that whole goal of just making sure that our community thrives, that has to start from the head down, right? So mind, body, and spirit.
Danielle, thank you for that transition, because we're going to talk about mechanisms. I'm sorry, we're going to talk about resources and mechanisms to educate. So the first resource that I can think of would be BetterHelp. And BetterHelp is a resource for mental health. I know we also have other apps and technology, which Danielle, you were discussing before we came on the call. We also have ZocDocs, and that's another resource for us to find doctors, and some of them may look like us. So I'm wondering, what other resources can you think of for us to find better health professionals, maybe some that even look like us? I know Dr. Tomi, you're talking about mentorship, bringing up more Black healthcare providers. So what are some resources for us to either help bring more mental health providers or healthcare providers into the field? And what are some resources for us to find them? Okay, so I've already mentioned BetterHelp. Can anyone think of other resources for us to either help bring in more mental health professionals, or more resources for us to find them?
I need to give that some thought. I do have one source that's not directly answering your question, but there is a Black Women for Wellness website, and I will send you that. And it's got a guide for self-care tips, and they do have resources on that. In addition, I know that a lot of African Americans have HMO insurance, and in those HMO panels, they are supposed to have a percentage of minority providers. And you may not get exactly one that looks like you, that's your same ethnicity, but you may get another ethnicity as well. But they are supposed to have a certain percentage, so you can call and ask about that and who's in your area, and you can press them on that. But the American Medical Association frequently has divisions in every city, and they have a list of providers in your area. So you can also go through their website and find providers. Even Google search for looking for African-American providers is available. I've done that before when I have friends that call me and say, hey, I'm looking for a Black cardiothoracic doctor, which is a rarity, by the way. Kudos to you. Congratulations. But I frequently do Google searches for that to find it. And then, of course, based on their insurance, they'll have to go within their network and in their panel a lot of times. But the insurance companies do have a responsibility to provide a certain population of minority providers as well. So there are ways to go about that. But those are the ones I can think of. And National Black associations and so on. But the American Medical Association has a Black physician network within it as well. So a lot of times you can go through that avenue.
Awesome. And before we move on to Dr. Tomi, Dr. Kynard, you mentioned HMO panels. What does HMO stand for?
I'm sorry, Health Maintenance Organization. So instead of having a private insurance, you're within a network and you have a list of who you can see. You can only go within your network to see providers that are participating in that plan. Health Maintenance Organization.
All right,
it's
thank
like
you.
Kaiser or something, HealthNet or Kaiser.
Okay. Dr. Tomi?
I think one of the biggest things that we can do is to kind of interject in the system early. So schools, there are many programs. I actually am involved in one this summer. We have a relationship with one of the schools in East Palo Alto, where we have a summer program at Stanford, and students can sign up for that program. And we have, surgical skills. We give different lectures, and it provides an opportunity for them to have insight into the medical field, but it gives them access to us as providers. And, you know, I think for me personally, I've always have this mentality where I will never say no. Like if someone asks for a mentorship, you know, I'm always happy to provide advice or help or a direction on how they can reach their goals, or just answer general questions. So I think just that interjection into schools, whether it just being speaking at schools, mentorship programs, is huge. The second thing I think is volunteer clinics. That's a huge avenue to accessing the community. And I think through that, not only are they able to get insight into the healthcare field, but you're able to educate them, which I think is another huge cog in this whole puzzle. Education, a simple education on big healthcare problems.
Awesome. And Dr. Tomi, I'm so sorry. I hope you expect to have a lot of direct messages for mentorship and help and questions. So just expect to see all of that in your Facebook and Instagram.
Sure.
All right, Danielle.
I agree with Dr. Tomi on making sure that we get in the schools early. Also, one of the big things is having African Americans look at the medical field as a secondary option. So there's, especially with nursing, there's multiple ways to get into the nursing field. You don't necessarily have to be bachelor's prepared. So, you know, you can start as a CNA, and which is one of the steps that I took. I worked as a CNA all throughout nursing school. Well, it was a nurse extern at the time. So it basically means that you were in a nursing program and you work through. And then once you, if they liked you and if they thought your work ethic was good, they thought that you could pick up on, you know, everything that you were learning once you took your boards, they would interview you and hire you on the spot if they felt like you were a good fit. So that's another way that, you know, for us, a lot of times we don't have the money and the means sometimes to directly go back to school or to spend that type of money. So there's, I think, educating our community on there's different avenues that we can take that sometimes better fit our situation, such as kids and money and you know, scholarships and grants. So you can also go the avenue of ADN, which is a 2-year nursing program. So there's letting our community know that there are ways to do what you want to do. Just how do you get in that avenue? So I think if you tie in what Dr. Tomi said about mentorship, then it gives our people the ability to say, you know what, that's not an unattainable goal. There's multiple ways I can go about it. How do I need to go about it that best fits my situation? It may be a little uncomfortable, but there is a way to ascertain that goal. And then as far as resources and organizations, I know there is which I'm a part of, there's a Black Nurse Practitioner Association. And a lot of times people ask, like, what's the difference between like a nurse practitioner and a doctor? So pretty much for nurse practitioners, they can pretty much provide you with a good amount of care that a doctor can. Most of the time, nurse practitioners we are in every aspect, but we don't do so we wouldn't do what Dr. Tomi does. We don't do cardiothoracic surgery or anything like that. Our stuff is more on prevention and maintenance. So we're kind of the bridge between how do we keep you healthy and maintain your chronic illness. And then doctors mainly focus more so like on the specialties and, okay, you have an acute exacerbation, things of that nature. So nurse practitioners are a great resource for chronic illness and maintenance and prevention. So if there's Black nurse practitioner organizations that you can literally like go to, like type in Black Nurse Practitioner Association, and just like with the AMA, you can look and see a listing in your city. Also, if you are a part of any organization, right? So word of mouth is a good thing. I'm a AKA as well. So when I first moved, I was like, I didn't know anything. So just talking to my sisters that were in AKA. So if you have any resources, network, use them, because a lot of times, you know, you never know who somebody may know. You know, just from this panel, I've met a Black cardiac thoracic surgeon, which is like a unicorn. It does not happen. I've worked in multiple hospitals. They don't exist. So networking like we're doing here. using any, if you went to a predominantly Black school, you can also do that as well. A lot of times what they do, especially with a predominantly Black university, they have latched on. A lot of times their medical schools are latched onto another one. So like with Howard, they have a big one with Harvard. With Simmons University, our big one is with Boston, Mass. And we also work with Harvard Medical. So, you know, those are other ways as well to kind of, they'll stick out. I mean, there's only so many Black providers. So they'll stick out and you can get some really good referrals that way as well. So I think my biggest thing is using your resources. If you know any Black organizations, if you have anybody you went to school with, those are big ways to find a Black provider, or Black, you know, nurse or practitioner or anything of that nature.
Great, thank you. I was definitely one that had to Google search Black doctors in the area, and I found one in a 50-mile radius. So it's not easy to find, but it definitely is worth it if you have those health concerns. So we need to do two things, right? So first, I'm going to have everyone give us about 20 seconds of final thoughts when it comes to the panel, and 20 seconds of final information you want to give. And then after those 20 seconds each, I'm going to summarize what we discussed, and then I'm going to wrap it up for us. Okay, so as you're thinking about what you want to say for your last 20 seconds, I want to give another piece of knowledge, another suggestion. So we've definitely discussed mechanisms for education, which include resources like Black Women for Wellness, HMO panels, American medical associations, mentorship programs, alternative ways to enter the health field, which may be from a CNA going to an RA, and then nurse practitioner, and then Black nurse practitioner associations, and honestly, just a Black blank association. So fill in the blank with whatever, just put Black and association on the outsides of it. Another recommendation that I have is instilling a sense of confidence in our youth. So for example, if I see a tall Black man, right, or a tall Black boy, my first thing is, hey, you look like a CEO, or you look like you would be a doctor, you know, as opposed to saying, hey, you look like a basketball player or a football player, right? So changing this narrative, changing these mental models, and instead of discussing or complimenting, you know, physical ability, we should start complimenting mental ability, and then maybe that will change the people that we have at the tables. Right. So I'd like to start with our 20 seconds of final thoughts. So can we start with Danielle, and then we'll go down to Dr. Tomi and then Dr. Kynard.
So my final thoughts, first of all, thank you so much for having me. I think this is amazing. It was an amazing opportunity to learn and grow. So thank you so much for having me. My final thought pretty much is, like I said, just making sure that you advocate for yourself, advocate for your family members, making sure that you educate yourself. A lot of times so I always tell people that my biggest thing is making sure that you're getting the right information. So Facebook is a great, like, quick snippet way to get information, but if you're looking for information, especially when it comes to the medical field, the big things that you want to make sure is that you're looking at actual research. So if you're looking at statistics from the CDC, if you're looking at statistics from the World Health Organization, if you're looking at statistics from the AMA, though, which is the American Medical Association, those are good places to start doing your research. Facebook is not a good place to start doing your research. It's a good way to kind of say, okay, I saw this, but that's not a good place to do your research. Also, if you're gonna Google something, a good way to know if it's a credible site is when you're looking at the subsidiary information. You need to be looking for references, what the references are, you know, do they have any, how recent the references are, right? So especially when we're talking about the medical field, information changes so quickly, almost daily. So if you could do it within a 5-year search, that's the biggest thing. So just education, advocation, those are my main.
Yeah, again, I just want to thank you for having me on this panel. It's a wonderful platform to discuss these ideas. I think two things that I want to touch on is, you know, one thing is we got to use the people that we have currently in the healthcare field as a resource. You see different other cultures, Asians are very successful wherever they are, Indians, Jews, and it's because they support each other at every level. And so they provide steps for people to move up. And I think that's what we need to do as African Americans. We have to support each other at every level, including the healthcare field. And then second thing is just prioritize your health. That's, if you can have everything else, if your health is poor, it's not worth much. So if you prioritize your health, that will lead to all these other great things, such as educating yourself and speaking up for yourself in situations where you feel like you're not being heard.
I'm going to piggyback on what Dr. Tony said. I think that a big part of all of this is that we need to rebrand ourselves as a people. And I think a lot of that starts with, as Danielle said, education is key to that. But I think what we have to do first is educate ourselves about who we are as a people and rebrand our thinking about our respect for ourselves, because a lot of that impacts how we are perceived and how we act in society and how we seek and are given healthcare. And I think if we look at really, there's some great historical documents out there that we need to start incorporating into our culture of knowing our history. Like Out of Darkness is an excellent documentary about our history and our strengths and just how we need to think of ourselves as leaders and mighty people. And I think if we start with that rebranding and rethinking and not seeing ourselves through how other people interpret us is a big part of it. And then start talking and speaking and looking at our tone of how we speak to each other, but how we expect to be spoken to and respected by other people. But we have to start with looking at our tone and our words that we use within each other. And we start needing to do, like Dr. Tony addressed, start supporting ourselves, going to Black businesses and just, building and only accepting. And even if you're not tolerating, if you don't think the business service you're getting there is not substantial, but teaching them or showing them what you expect and helping them to reach that level, being empathetic and patient to help them do that. But it needs to be a community force, a cultural force like the other cultures have done. We need to stand to each other and learn about our history, learn our culture, and move forward. So I think we need to start with knowing our self-history and then doing self-care. I can't say that enough, of de-escalating and getting our body holistically, or getting us holistically healthy, mind, body, soul, and spirit. Okay, so that's really my big emphasis, and starting from within and going from there.
All right, thank you so much to our amazing, powerful, brilliant, magical panelists. I really appreciate it. Thank you for making my job so much easier. I want to remind everyone that this video will be posted on YouTube with a link on the More Than a Protest Instagram and Facebook pages. There were no questions that came through Facebook during this session, but if they do have questions, we will post those as well on Instagram and Facebook. Once again, I'd like to thank the VIPLA organization for giving us this platform. Specifically, I want to thank the Executive Director of More Than a Protest, Dr. Erica Waller, Public Relations Director, Jalaisha Simpson, and the Creative Director, Kimani Anthony. I am Dr. Jasmine Austin, and thank you for joining us. And as Representative John Lewis would say, thank you for getting in good trouble, necessary trouble, to help redeem the soul of America.